Good evening. Welcome to the second FACFAS Zoom room. We have 10 different programs for you tonight, and tonight we're going to start off with Dr. Mark Allen. So, Dr. Allen, if you'd like to share your slides.
Sure. See how I get there.
We'll be monitoring for questions throughout, so feel free to put something into the Q&A portion, and at the end, I will ask the presenter.
Are you ready for me to start, Mark?
Oh, yeah, please share.
Oh,
Feel
excellent.
free.
Do you guys see that?
Not yet.
Uh, let's share. Let's see. Go back over here. I'll hit share again. Let's go up here. How about now?
Perfect.
Okay. And how about now?
Perfect.
Excellent. All right. Well, thank you everyone for attending. My name is Dr. Mark Allen. I am the Fellowship Director at the Sports Medicine Associates Foot and Ankle Fellowship in San Antonio, Texas. This fellowship is centered within the Texas Center for Athletes, which houses the practice of sports medicine associates. The practice as well as the building you see here was founded in 2004. The building was built in 2006. The building sits within the heart of the Texas Medical Center. This is a 135,000 square foot building. This would be your home primarily throughout the course of the fellowship. This building was built in conjunction with the San Antonio Spurs basketball team, and it houses 21 different medical specialties and is the home office of Sports Medicine Associates. Within this building is our freestanding surgical center of 6 different rooms, and it does roughly 600 orthopedic and podiatry cases per year. There's also on-site housing for the fellows. My fellow lives just across the street from the building, and he walks to and from work each day. Our practice itself is composed of 20 different doctors. These are composed primarily of orthopedic surgeons, primary care sports medicine docs, fellowship trained in sports medicine, and myself, as well as nurse practitioners and PAs. The practice today has 8 different separate locations throughout San Antonio with 3 different fellowships. One is sports medicine of orthopedics, one is sports medicine and primary care of sports medicine, and the last one is foot and ankle fellowship with myself. Within the office itself, we have freestanding MRI, 3 Tesla. We have now a weight-bearing CT scan for us to be able to use, physical therapy, X-ray, and all other passive forms of ancillaries and such for the patient. The goal was to try to take the building and place the athletic person within inside of it and not have to go anywhere. Again, there's 8 different locations, but primarily you'll spend 90% of your time in this building. The faculty of the fellowship consists of myself as well as Dr. Liliana Ogden, who we brought on approximately 2 years ago. Liliana is a foot and ankle orthopedist who did her surgical training at Emory University. We are then supplemented with Dr. George Liu and Michael Van Pelt from UT Dallas Southwestern. They play a very active role within the fellowship for academics as well as opportunities to rotate with them. Dr. Stephen Smith was one of my first fellows, and Stephen is still involved. Dr. Kyle Ottman and Jeff Glevis, these are both orthopedic surgeons that are fellowship trained in sports medicine. My last 2 partners here that are involved, Dr. Lindsay Stevens and Elliot Young. These are primary care sports medicine doctors who are also fellowship trained in sports medicine. Your interaction with each one of these people will be dependent upon schedule, availability, as well as your motivation to want to be involved with them. The fellowship overview, again, was founded in 2022. My current fellow is probably one of the nicest people I've ever met in my life. His name is Surreal Amin. He's in the upper left-hand corner. Fellow for 2006 and 2026, 2027 is Dr. AJ Chun. He's coming from the Northeast Coast. The salary for 2027 will be approximately 70,000 per year. Could be more, it won't be less. Calendar year for me is a roughly 13-month fellowship because I like to have about a month where there's an overlap of the outgoing fellow and the incoming fellow to make the transition for everything much easier from the office to the clinic to the surgery center and such. The fellowship itself will always include your full benefits of malpractice, tail coverage, medical benefits, disability, etc., and 401k contribution. Our fellows are fully licensed within the state of Texas and fully insured and credentialed on all of our insurance panels as a full functioning physician by themselves. The fellows, again, can function autonomously within the clinic as well as in the hospitals. The fellowship overview, what I like to say is this is your fellowship. It's not mine. And so what I ask you to do as being a fellow is tell me what you want and tell me what you need. The other thing I like to do is when the fellows come in, I like for them to write out a list for me of the things that they feel exceptionally or at least well qualified in coming out of their residency, and then give me a list of the things that they don't feel as comfortable with and that they would like to achieve. So I have a roadmap in which we can pursue your education. I like to say you have 12 months to train and the clock is ticking. I'm the type of guy, I'm awake every day at 5 a.m. Carpe diem. We work in this fellowship. I just want to make that very clear. We have hours sometimes that can be very difficult. The hours, again, maybe between 8 and 12 hours a day. You're going to have 5 clinics per week at the Texas Center for Athletes with myself and potentially with the other physicians. You'll see 30 to 35 patients per clinic. A clinic is a half a day from 8 to 12 or from 1 to 5. Approximately of the patients you're going to see, 40 to 50% of those at all times are new patients within the clinic. There's going to be a high volume of sports-related injuries of all ages and sport level. You'll see approximately 6,500 patients per year. That's with myself. Your surgical volume will approach and or exceed 500 to 1,000 cases per year, depending upon how hard you want to work. There's always something to do. However hard you want to work, I've got work for you to do. It may not always be with me, but we've got work to do. Again, every Friday morning, this is mandatory. We have grand rounds with UT Southwest Dallas over Zoom, where all cases are presented, and education and basic sciences are going over. This is with Dr. Liu and Dr. Van Pelt. Traveling fellowship opportunity is available to go into Dallas to work with those two for 1 week, 2 weeks, 4 weeks, however long you determine that you can be away from your family. Saturday Sports Clinic always occurs annually. This will be throughout the duration of the fellowship. This is every week. This is a Saturday Sports Clinic. It's exceptionally busy during the months of late August and December as we're triaging uh, acute sports injuries that have occurred on Thursday or Friday nights from all over South Texas. We employ nearly 300 athletic trainers that go through the entire South Texas area. And each one of these Saturday morning clinics will see anywhere between 50 and 100 patients that will be triaged through our system. Sports team coverage that will vary from Division One, Two, Three, and even some of the professional ones, depending upon your ability to want to go cover these. Same with athletic room and trainer coverage. If you want to be able to go into the athletic training rooms, we have that available to you. Sports team coverage is going to be on a Thursday or Friday or Saturday night on the sidelines or on the court, whichever you choose. Call coverage. Call coverage is optional for you. I do not take call in the hospital, but my partners do. We take call at 4 different separate hospitals. If you choose to take call, I can set that up for you. You may like that. You may not like that. The option is yours. Again, fellowship overview. The fellows will see all clinical patients and staff by themselves as well as alone. The autonomy in the clinic and the surgery is earned, it's not given. The fellows are responsible for all patient workups and tentative decision making. Constant teaching and feedback will occur on a daily basis. Journal club is monthly, basic science review is monthly, grand rounds is weekly. Submissions of a publishable research submission to JFAS is mandatory, and you will have quarterly reviews. Also, the fellows will be taught how to bill for every visit, procedure in clinic and the OR. You will learn how RVUs work. You will learn all aspects of a revenue cycle within a practice. You will also learn passive income streams. You will also be taught the nuances of forming an S Corp, LLC, and trusts. Your fellowship overview again, I expect you to attend with me or by yourself the various meetings of industry. These are examples of some of those that have been covered before or attended by the fellows. I will take you to these or you will go by yourself, but money is available to send you to anything you have a great idea to go and do. Again, tell me what you need and we can make it happen. Again, so these are the ones that I like to send folks to. If you notice, there's an emphasis on billing and coding, as well as risk management as much as there is on surgery and clinic. The typical clinical, I asked my last fellow, Seth, to write down. I said, tell me what you think your typical clinical day is and surgical day. And this is what Seth came up with. If you notice in the right lower hand corner, he's placed an X through diabetes. I do want to make that very clear. This is not a surgical fellowship that has diabetes and reconstructive surgery in it. It will not. There's enough of these that we have that are very good. And if that's what you're interested in, then I would expect you to go do one of those and not come here and be frustrated. So this is a typical clinical surgery week that Seth has written down. And the common surgeries, again, these are a little bit of everything. And we do pretty much everything that you would like to do. Um,
Dr. Allen, let me just ask you one quick question that's in
sure,
chat before we wrap up and go on to the
sure.
next one. They just wanted to know if you can sponsor H-1B fellows.
I'm not sure. That's a good question, and it's not a question I've ever had posed to me. Um, it's a possibility. I don't know the nuances of the legality of that, but if it's possible, then we can do
Great.
it.
Thank you. We really appreciate your time and your presentation. And how, maybe you want to tell people how they could reach out to you.
Yeah, if you please go back to that first slide, and I can maybe get you back there. I ask you to go ahead and just call me directly if you like. My number is 210-379-0951. And my email is mark.allen@smastx.com. That's on the first slide. Feel free to contact me directly.
Great. Thanks. All right. We're going to go on to the next one, which happens to be me. So just to, I'll get that H-1B question off for our fellowship. I'm Dr. Mark Solomon from the Pediatric Foot and Ankle Fellowship. We do not have the ability to sponsor an H-1B visa. Many times you do have to be affiliated with a academic institution or university setting in order for that to get that up and running. So let me just put great. So these are my partners in the bottom. You're in a group. There's 8 of us. I'm the only podiatrist in our group. There's 7 pediatric orthopedic surgeons. Um, so this is where the primary faculty is, and then you get to work. And I have a list of faculty down the line that you'll be able to see. But you get to work with Dr. Fleming, Dr. Bricado, Dr. Buddha, at different facilities. So let's just kind of go through it. So you don't have a lot of time. So most of you have had a significant amount of exposure to adult patients. What we see in our pediatric practice, my practice is about 80% peds, 20% adults. Um, Kids are not little adults. You get to learn how your intervention will affect their growth and how growth will potentially dictate what your intervention is. It's kind of a yin yang type of situation. It does open doors because it is a very, very unique opportunity. That is, there's really only one other program that has some pediatric training that I know of. We started this, it was about now almost 8 years ago, after I'd been doing a bunch of residency site reviews and saw that what we offered in our practice was very unique. Uh, so I put a couple different types of cases that we see. There's a lot of kids that are syndromic, so you get to learn how to work up kids with syndromes and learn how to quarterback those types of surgeries and treatments. There's a kid on the bottom here that had something called Town syndrome, had bilateral severe pes valgus with a tailor neck deformity that we ended up having to reconstruct. The kid on the top here, if you can see my little pointer or not, had a polydactyly surgery that was done, I think it was in another country, and ended up coming to the US for reconstruction later in life. And you can see that they took off part of the second metatarsal and left a bit of a deformity because they didn't fix the accompanying delta phalanx that was in the base of the proximal phalange. You get to see a lot of pediatric sports medicine. What's hot right now, and every month is obviously very different. What's hot right now is that we're in the height of gymnastics competition. So we see a lot of gymnasts. There's a lot of the spring sports starting. Basketball isn't full. Uh, it, Plenty of injuries for every single sport possible. There's Olympic caliber athletes in fencing. One of my partners is a two-time fencing Olympian in epee. So there's a very nice exposure to pediatric sports. There's a good amount of deformity correction and very complex pathology. Will you forget your adult skills? No. There's Dr. Fleming, who does a tremendous amount of trauma and total ankle cases. This is one of the cases that he recently did that he had to revise out somebody else's ankle implant. So you get a lot of great experience with that. This is a pilon that he repaired. He loves plates and hardware, as you can see, lots of metal in this patient. And then you get an additional understanding of how to do some very complex deformity. One of the greatest compliments I think I was given was our fellow about 2 years ago. Dr. Schneider's had training that was by the book from Emory. And when she came to our office after about 4 weeks, she said it was like I had told her that Santa Claus didn't exist because she learned that there was like completely different ways of doing things. A lot of the cases that we do are MIS, and she got to see a lot of deformities that were very rare and complex. There's a good amount of pediatric trauma, as you can see, there's a Salter Harris here that was reduced. There's a patient on the bottom corner here that had a neurofibromatosis with congenital pseudoarthrosis of the tibia that we ended up reconstructing as well. So you get a very nice um, experience, and when you leave, you really won't be afraid of seeing just about anything or working it out. As of now, because I like to put by the numbers, this is our current fellow, Dr. Hugh from MedStar. He has 222 cases. Our period is from August to the end of July. So he's about a little over halfway through. So 24% of the cases were pediatric, 17% were adult ankle fractures or calcaneal fractures, or even talar fractures. We had a bunch of. And then major reconstruction is about 18%. Total ankles were 8%. So he had about 17 of them, which is a pretty good number for a fellowship year. And then forefoot reconstruction, bunion or hammer toes were in almost all of them were done minimally invasive. Infection, limb salvage is about 6%. I see zero diabetic uh, in my practice. So that's not something that I do. One of our previous fellows, Dr. Dong, Johnny Dong, who just finished his fellowship and works nearby, does participate with our fellowship and does these cases. Just to speed it up, a lot of different type of pathology. This is a patient on right underneath the clinic experience that had something called Trevor's disease. I think if you don't do a pediatric fellowship of some sort or work in a pediatric orthopedics, you probably will never see this in your career otherwise. But this is kind of like a cool case. The patient on the other side had a sports medicine injury where they had chronic ankle instability, and we reconstructed it, did a scope, removed that little secondary ossification or os subfibulari. We're the only Ponseti center in New Jersey, so you get to see a lot of clubfoot vertical talus and other types of congenital deformities. There's significant amount of mentorship in teaching. You get us every single day, one of us at least. But we do allow some surgical autonomy when you're taking call. You do have an opportunity to teach residents at programs nearby. I see one of them's on tonight as a presenter, and there's structured case discussions every Tuesday night with multiple of our previous fellows and attendings. Um, this is a list of our attendings and our fellows. We're going on our ninth year in fellowship. Um, this is a AI did a little bobblehead thing of all our previous fellows. They're what this really does is open up opportunities for you. Yeah, there's a movement around the country to only allow pediatric surgery or surgery under age 18 at certain hospitals, especially children's hospitals. Our fellowship gets you into unlocks those doors for you so that you can get in and get staff privileges. So rare training experience. very high surgical exposure to complex cases and mentorship. We definitely have the ability to open doors for you. So just wanted to thank you and see if there doesn't seem to be any questions, and I answered the H-1B question already. So I think I'm going to pass the baton on to Dr.
Oh, actually, Dr. Salman,
Yeah.
there's one question in the chat.
Oh, okay. Just popped up. All right. So that's a great thing. So my personal philosophy is the way I look at these kids is, what would I do on my own child? That's the golden rule. So that's the first and foremost. Second way you kind of look at everything is you have to understand kids are a lot like bonsai trees. So bonsai trees, you don't make any big movements on that. You kind of do slow little trimmings. You take off a little bit, you watch it over a period of time, and then you see how they grow out into that. So that's maybe like the 1 second or 10 second answer to that question. But to really understand that, spend a year with us. We definitely welcome people to come and visit. Uh, we're always available. I wish I could go back and there it is. Feel free to contact either myself or our fellow. And this is the contact information for both of us. Oh, there's another question, I guess. So specialize in pediatrics. I mean, if you're doing the types of cases that we're doing, which is like the major reconstructions, you're not going to limit yourself on the boards because there's really no distribution as far as pediatric and adult patients. You just have to have the ankle, the rear foot, the forefoot, all the different categories met. You can definitely get that in pediatrics. So I think that answers everyone's question. Feel free to reach out to me. Happy to answer everything, but I want to give everyone their due time. So we're going to go over to our next speaker, Dr. Burgess. If you want to share and turn on your mic, that'd be awesome.
I think I'm here. Let me pull this up here. All right, thank you. Thank you for having me. Enjoyed the first two presentations, going through the program. I'm a director of a program called Illinois Bone and Joint Institute. Obviously, it's in Illinois. I was born and raised in Illinois, so it's kind of my home state, my home turf. The practice that I'm with is a large orthopedic or musculoskeletal group. We're one of the largest in the country. We have about 220 providers, and we're kind of divided up into little subgroups, if you will. Specific to the fellowship, we have two clinic locations in Joliet, New Lenox. I'll show you in a second, kind of just roughly where that's at. We are on staff at two hospitals, but do very, very little in the hospital setting. And a good majority of our stuff, probably 9% of the work that we're doing is done in a surgery center facility. So I don't want you to think we are in Chicago. We're not. We're in the southwest suburbs. Mile-wise, it's probably 35 miles from the city of Chicago. And that can be anywhere from 35 minutes to an hour and 15 minutes, depending on traffic. So we are west and southwest suburbs, mostly southwest. Here we go. So yeah, so 40 to 45 miles outside the city. Here's the faculty that I'm lucky to have, and our fellows very lucky to work with. Myself, two other podiatrists, Ed Rakovich and Gaurav Vijaria. Ed's in a very busy orthopedic group, and Gaurav's in a very busy multi-specialty group. And then our fellow also scrubs with two foot and ankle orthopedic surgeons, David Garris, who trained at Duke, and Dan Dean out of Baltimore. And kind of like Mark was saying earlier, we have this opportunity for the fellow and really just let the fellow kind of do what they want, cover what cases they want. They don't have a real strict schedule in terms of who they have to cover and when. We do give them a lot of autonomy to kind of cover whatever cases they want to that day. So here's our past fellows. So we've had this program now going on its 6th or 7th year. All my fellows, got jobs before they finished fellowship. 3 or 4 of them ended up in orthopedic groups. One is out in Denver, and my current fellow already has a job with several months left to go in fellowship. Here's a current picture of my fellow from this morning. She flew to London last night. She's doing a 2-week rotation. It's our first time doing this, but she's doing 2 weeks with MIS guru Robbie Ray in London. So she landed today, and she's going to be covering cases with him for the next 2 weeks. So it's something we're excited about. She just landed today, so I can't say for certain that it's going to continue, but more likely than not, we hope this becomes a regular part of our fellowship program, and that's an opportunity to spend 2 weeks over in Europe working with a foot and ankle orthopedic surgeon. Our program, kind of a little bit of everything, fair amount of trauma, sports medicine. We do a lot of MIS, whether it's forefoot stuff, bunions and first IBJI fusions. We do a lot of our midfoot stuff minimally invasively, a lot of our ankle and hindfoot stuff minimally invasively, as well as a lot of our trauma. So, something where we try to do it minimally invasively unless the pathology dictates otherwise. Here's my current fellow's case breakdown. She's estimating that she's going to do about 750 cases. And that's really just, her covering whatever case she feels like that day. But unfortunately, she's missing, a handful of other cases almost on a daily basis. So this is her, kind of cherry picking the cases she wants to do. Again, kind of a fairly balanced mix of trauma, tons of ankle fractures. We're not a huge trauma center, so we're not doing, a lot of level 1 type trauma. A lot of these are just patients that go to the emergency room with a simple bimal. They're reduced, splinted, and sent to clinic. I do, again, a lot of elective forefoot stuff. Bunions, hammer toes is a big part of our practice. And again, arthroscopy. I think she's going to do maybe 15 total ankles this year. A little idea of what we're doing. And then lastly, to wrap it up, here's my contact information. Easiest way to get a hold of me is just email, so it doesn't get buried in text message or other email addresses. So if you're interested in our program, best thing to do is first reach out via email. We do just use the standard ACFAS application. We do offer an initial Zoom call followed by a site visit, and usually stay in constant conversation regarding the process throughout. So open to any questions. I'm not sure where
So I have two questions for you because
Sure.
it's constantly getting asked. Are you able to sponsor H-1B visas?
I am not, no.
And then the other one is, I don't know if you may have answered this already, but when does your program run from? What month does it start? What month does it finish?
Starts end of July. I usually leave it pretty flexible, depending on when they finish residency and if they want to travel and how quickly they can get their license. So I would say it's generally end of July, and usually runs through the end of June.
Okay, great. I really appreciate your time, and you gave some information on how people can contact you. So hopefully, anybody interested can reach out to Dr. Burgess. Thank you, Doc.
Thank you. Thanks for having me.
So next, we have the man that needs no introduction, Dr. Larry Rubin. So I'm going to let you take it away, Dr. Rubin, if you want to share your screen.
Oh, can you hear me?
Yes.
All right, great. I apologize, everyone. I had a nice slide presentation and everything ready to go, but we just stepped out of an operating room moments ago. It's a 1-year program. It starts August 1st and ends July 31st. Our philosophy is quite simple. This is not here to teach you surgery. You're supposed to learn that in residency. We're here to make you into a surgeon. And why is that philosophy? Because I never ever wanted this to be a 4th-year program. I happen to have done a 4-year residency, and I understood what that was. This is different. For example, your schedule is Monday all-day clinic with me. I find that incredibly important. In the beginning, every fellow looks at the post-op wounds and goes, "Oh my gosh, that does not look good." I'm like, "No, that's swollen and red. That's a post-op normal 2-week looking or 1-week looking course." And you learn quickly what a post-op's supposed to look like and what a pre-op looks like. When you're in the clinic Monday, you're working up patients. That becomes important because as a surgeon, you don't just perform the procedure, right? You have to understand the difference between, do we want to do a total ankle? Do we want to do an arthroscopic fusion? Do we want to do an open ankle fusion? Do we want to do a tibial osteotomy? Which one is which and why? So it's not just performing the procedure. It's picking the correct procedure and dealing with that procedure during the postoperative period. So your schedule looks like Monday all day is clinic with me. Tuesday, Wednesday, and Thursday is surgery all day long. And then Friday is part clinic and part surgery. Our current fellows, a little over 280 cases as of today. So your volume is good, but it could be higher, but I won't sacrifice the clinic days. I think those are critically important for your growth as a surgeon, to not just know how to do surgery, but to recognize who gets what procedure and when. In the clinic, again, you see the pre-op and then you learn which procedures. So you see the patient before I do. You walk in, you look at the x-rays, you look at the CAT scans and kind of decide, hey, I think this is what this guy needs. And then we have a discussion about it. Our program, you will not do 100 of any procedure. You just won't. You'll do a couple of everything, from lesser MPJ implants to total ankle revisions. You'll do every procedure known. We do it all. There's three docs in the fellowship, and you do 100% of the cases. There's no residency associated with our fellowship, so there's no fighting with residents. There's no picking cases. You do what you want to do and when you want to do them. We don't care what program, which surgery you do on what day. Actually, I kind of like when you don't scrub with me because I get to do a little surgery on my own. So sometimes you pick me, sometimes you pick one of the other guys. You get a lot of time with the fellowship director, which is me, not just on Mondays in the office and not just in the OR, but we actually share an office. So usually the day before my big surgeries on Tuesdays and Thursdays, the night before, we'll sit down, we go over the x-rays, the CAT scans or MRIs, and we discuss the case. We discuss the equipment we're going to bring in. We discuss, or I'll go into that. We discuss how we want to do the case. And I usually kind of give you a talk. I kind of say, hey, here's where you're going to mess up tomorrow. Here's where you're going to have a problem. So that you're kind of prepared, right? You're using my experience in that when you get in there and you go, and I'll say, doctor, we discussed this yesterday and I told you you're going to be in this situation. You're about to be in that situation. So for the fellow, they get a prep before every big surgery day with me on what we're doing. I talked about hardware. In this program, I allow the fellow to order the hardware with my permission, with going over and reviewing with me. I think that's important because you have to now research which equipment you want, which hardware you want, which plate and screws you want, and why. You also learn to deal with reps, and reps are a special way to deal with, right? Was it about a week ago? I had to go through 4 reps to go from the doctor's lounge to my OR. They were just one after the other. And as a surgeon, you better get used to dealing with that. And as a fellow, they're all want to talk to you. Can we go out for a glass of wine? Can we go out for dinner? Can you use my plate? Can you use my screws? I also get to, when the reps hound me, I'm like, I don't get to make those decisions. You got to go through the fellow. But it's a growing experience. And I think the fellows enjoy that. You also get to do surgery on your own. So not the bigger stuff, but little stuff, amputations and INDs and that kind of stuff. We want you in the OR by yourself. One, some of those cases I believe counts towards your boards, but more importantly, your growth as a surgeon is learning to control the OR, to being the captain of the ship, and not being the captain of the ship when I'm in the room, but being the captain of the ship when you're the captain of the ship and no attending except for you is in the room. So we also find the fellows really like that they get to do surgery on their own. And again, not bigger stuff, but they get to do some of the smaller stuff on their own. No residency, a lot of revisions. So we do a fair amount of revisions in this practice. Myself and Scott Vantry both get a lot of revisions sent in. As far as our current fellows or our past fellows, I think the one coming in August is number 7. I'm proud to say every one of our fellows is employed. Our current fellow already has a job that she's very happy with. Our fellows are employed from either either single specialty practices in foot and ankle surgery, hospital-based orthopedic groups. Everyone is employed and everyone has done everything they're supposed to do post after graduating, which includes external fixators, total ankles. So they don't just do it in fellowship, but clearly it sticks with them, and they do those in private practice as well. And that's it. I'll take any questions.
So, Dr. Rubin, let me ask you a couple questions here. First of all, one of the popular questions that we've been getting asked is whether you have the ability to sponsor H-1B visas.
We have not up to now. I don't know what that entails. I would look into it, but we have not up to now.
And typically, when does your fellowship start and when does it end?
August 1st to July 31st.
Great. What qualities are you looking for in fellows, potential fellows?
Intelligence, independence. We encourage that. I encourage the fellows. There's my fellow now. She's with me, just coming out of the OR. We encourage them to be very independent, to say what they want to say. We will have discussions about what procedures, and if you don't like what I'm picked, let's have at it. And let's have that discussion. I think that gives us growth. So I'd say intelligence and independence. We'll develop some of those surgical skills with you, but again, I expect most of those surgical skills were developed in your surgical residencies.
I mean, I think that's a
I
great
think
point.
those who know me, I'm a big proponent of foot and ankle surgery, not podiatry. This is foot and ankle surgery. It's what it's intended for. That's what I do, and that's what you become, a foot and ankle surgeon.
Well said. I mean, I think a lot of what you said is I agree with 100%, which is that this is not a replacement for residency. This should be, you should be having an experience in addition to your residency. I think having that the clinic hours, like you said, is ultra important because coming out, I think there's not enough clinic hours during residency, and being able to work with an experienced surgeon side by side and get to see what they see through your eyes in both the perioperative period helps with proper patient selection and managing any of the post-op situations that any of us can kind of get
Right.
ourselves into. So I think that
Right.
you hit it right on the nose with that.
To that point, Mark, when you're a resident, you walk in the OR, you do the procedure the attending told you to do, and you do it with the equipment that the attending picked. That's residency. In fellowship, you do the procedure that you picked with the attending. You had the discussion the night before about that case, and you're using the equipment that you picked. That's a difference. So it's not a surprise to you when you walk in and the attending says, "We're doing a first MPJ fusion." Well, you and I have had that discussion. MPJ fusion, MPJ replacement. Which one we want to do? Which equipment are we using? Why are we using that equipment? And again, when you walk in, that's your case.
So if somebody, a potential fellow, would like to reach out to you, how would you like them to contact you or your program?
You could absolutely contact me through my email. It's Rubin.FASV, foot ankle specialist of Virginia at outlook.com. Also through ACFAS. So just send in your ACFAS application. But I think in the ACFAS website, my email's listed.
Right. So the ACFAS Fellowship website will have all the listing of your current contact information.
Absolutely.
Right.
We don't require a visitation, and we'll be interviewing probably right after May 1st.
Perfect. Thank you so much, and
Thank you.
get home safe. Hopefully,
Thanks,
get some
guys.
rest.
Thanks.
And you're welcome. Next, we have a Dr. Eng at Colorado program, which you can see from my background is someplace that would be awesome for me to be at as well. But Dr. Eng, if you want to share your screen.
Trying to do that now. And is it
Great.
working? It says it's paused. Shoot. My fellow Oliver, are you on? Yeah. Can you share?
Yeah, let me pull it up 1 second.
So part of the fellowship is the fellow runs all the AV because I am not very good at it. So, thanks, guys. My philosophy or my program here in Colorado is very similar to Larry's. Shocker, we're the older guys on the screen here. So, my goal of a fellowship is very much like Larry's. Is I want to teach you guys how to think and how to work through cases, and to develop yourself as a foot and ankle surgeon, just like Larry said. So, I want to do Dr. Rubin's fellowship, but I'm too old now, so. I run my own. We work with the residency program currently, which may or may not be around in a few years due to funding from HCA, but currently we work with the residents. We're primarily reconstructive fellowship where we do a lot of total ankles, a lot of revision cases. The schedule is usually Mondays, surgery all day. Those are train wreck days, revisions, Charcot, total ankles, total ankle revisions. Wednesdays, mostly elective days where we do our simple fusions like subtalar joint fusion or sports medicine type of procedures. Um, I agree 100% with my previous directors that my goal is to teach you how to think and how to be a surgeon. Oliver is our current fellow. We hired him just because he is kind of epitomizes what I'd like to see in a fellow coming through, learning how to think. Currently, the fellow primarily works with me. They have the opportunity to work with other people in our group, but currently the fellow spends most of their time with me in the office Tuesdays, Thursdays, Fridays. After the first 6 months, the fellow runs their own clinic. I think that's important that you learn how to run a clinic on your own and learn how to be efficient in clinic. On Tuesdays is a busy clinic day. We see up to 70 to 80 patients between me and the fellow. It's 12 months. We start August 1 and July 31st. 500 plus foot and ankle surgeries, that's just with me primarily. There are some other opportunities, like I said, when Oliver stays on next year, the opportunity to work with him is available. We work with a lot of ortho-oncology that we do limb preservation conference with, that you have access to them as well. And we may eventually start an ortho-oncology rotation as well, but we haven't done that quite yet. We do over 50 plus total ankles a year. This is really ramped up over the last few years. I'd say probably 20 of those are revision total ankles, the other 30 are index primaries. We use 3 systems primarily, and we're kind of the dumping ground for failed surgeries and revisions. We're part of a limb preservation society where we get stuff sent in from surrounding states and in all around Colorado in general, just for bad cases that just didn't go well or complex reconstructive cases. It's pretty much my goal is to get somebody who wants to learn, wants to think, wants to be a surgeon that's taken to the next level and wants to be better than average. I think that's a problem we see these days. I will push you, I will grill you, you have to have the thick skin. And sometimes I'll call you bad names, but that's all in the part of just trying to get you to think better. So that's kind of our fellowship in a nutshell. I'm going to leave the rest of the time to Oliver to kind of give his experience so far over the first 7 months or so, and what he sees he has a closer relation to what you guys are looking for, being looking for fellowship. So Oliver, I'll turn the rest over to you and go from there.
Yeah, I think a big key to fellowship and what we provide is it's not just a 4th year of residency. It's learning to think through every stage of it. Kind of was talked on before, but you start to pick up on in clinic of who's going to do well with surgery and who's not, and then dealing with the potential complications and situations in clinic, I think has been huge. And then after the first couple months, when you're alone on Fridays, you get to make some of those decisions, on your own. And Dr. Ing's always available through text or call if you need, something to bounce off of him or something. But it's been a good transition out of residency where you're kind of always being watched, always being told what to do, and to really have to start to think for yourself of, even some simple patients in clinic of like, well, what am I going to tell this person? How am I going to tell them this? And even start to have some of those tough conversations with patients on your own about, hey, you've got a non-union, but this is what it means for you. Things like that. So it's been a great year. I feel like it's been a huge growth and me professionally and personally, it's been really great working with Dr. Ng, and so far so good. I guess here's some examples of the kind of crazy cool cases that we're doing. You can see we do a lot of 3D printed custom stuff. So we have about a weekly, if not every other week, meeting with the companies that are making these devices, and go through all the planning stages, which I have found to be super helpful. In residency, I did some cases like this, but the attending would come up with the plan on their own. You wouldn't have any say or thought in the planning or going over the plan. And sometimes it's been really helpful, especially working with Dr. Ng, who has a ton of experience of how he looks at the plan and how he tells the different companies on what to change and how and why, and all the nuances that go along with that. So I feel like that's been a really useful thing. So, yeah, that's pretty much the
So let me
fellowship.
ask you a couple of questions then.
Yeah.
First off, are you guys able to sponsor H-1B visas?
No, we unfortunately our fellowship is funded directly through the orthopedic group, so we can't do H-1B visas.
Okay. Where do most of your fellows end up after graduation?
They've been everywhere. I have this is Oliver's my sixth fellow. I have a fellow out in Kaiser, works with Kaiser. Another one works with orthopedic group in Louisiana. Another one works in orthopedic group in Florida. One's in two are in private practices. Just it varies on what they want to do. And currently, Oliver is going to work with us at our orthopedic group, just to help me with, I'm getting old, so we need somebody to take over some of this stuff. So,
Not
and
that old.
feeling it. But yeah, so the fellows have all done well. They all have jobs, or they're all working. Nobody's in jail, so everybody's good. But yeah, it's a fellowship, and one of my fellows had the best kind of comments. Like, doing a fellowship when we did it here with us is like being in practice for 5 years. So you already have the experience how to manage patients, how to work up these kind of just crazy cases and try to think through them. And it's great watching the development of the fellow from day one to 6 months to a year out, and seeing their thought process develop, and seeing you know the fellow become a high level foot and ankle surgeon. And that's the goal of this, right? We do work with the residents. We have academics with the residents right now, and the fellow is actually teaches the residents at this stage. So, if I'll sit back, we'll do a case, a resident may come into the case and scrub with us, and I'm sitting in the corner talking to the rep and the nurse, and Oliver is working with the resident. They're doing the case. Something happens, you get stuck, or something doesn't work, I'll pop in, but majority of the time, like I get kind of bored the second half of the year. I sit back and kind of let them run it, and it's great to see them develop and get better and better. So, I was always very skeptical starting a fellowship 6 years ago, and I'm really glad we've done it, and we've seen the next level of surgeons come through, and hopefully these will be the next leaders of our profession.
When is two final questions? When does your program run from? What month to what month? And
August,
how do you want that prospective fellows to contact you?
August 1 to July 30, the end of July, whatever it is.
Okay.
Contact us through, I think our email's on here on the next slide, Oliver. You can advance it.
Oh yeah, here it is.
We use that ECFAS fellowship application as well. Most of the time the contact, Oliver will respond to you, or the current fellow will respond. And yeah, that's about it. There's no trauma call or anything like that. You take call for the patients that we do surgery on, we work on, but you're not doing a open fracture in the middle of the night. You do have the opportunity to operate on your own if you want to, on certain cases. And if there's cases you want to book on your own, I can run backup, pretty much is what it is. So, but that's kind of the goal, is, to develop you as a next level type of surgeon.
Thanks. I really appreciate your time. The only question we got from the audience, they want to know who was a better skier, you or me. But I know you don't ski, so
I'm broken. The knees are shot, back shot. If I got on skis and fell, I wouldn't get up. So at least we have Oliver starting with us next year. So if I do wreck myself, we have somebody to continue to push the fellowship going forward.
Oliver, do you get any time to ski?
A little
Better
bit.
say
I
no.
just had a newborn 7 months ago
Oh
when I
yeah.
started fellowships.
Well, in 2 years
That's
we
what
can
I've been
teach
doing.
them how to ski.
Yeah, someday soon.
Awesome. Well, I really appreciate your time and your presentation, and your information is on the slide here. Plus, it's also on the ACFAS Fellowship website. So, thank you guys tremendously.
Thanks, Mark. Appreciate it, man.
Take
Thanks.
care. So, our next program will be Dr. Brownell from the Penn Lower Extremity Plastic and Reconstructive Surgery Fellowship. So, Dr. Brownell, yeah, great.
Awesome. Can you guys hear me?
Yep.
All right. I lost the screen, so I can't show my video here, but at least you guys can see my screen. So I'm Jake Brownell. I'm the fellowship director at our Penn Lower Extremity Plastic and Reconstructive Surgery Fellowship. So thanks everyone for tuning in and letting us highlight our program. It's actually been around for quite some time. We had a couple year hiatus and now we're back full in effect. So we're happy to re-engage this fellowship and kind of have you guys learn more about it. So this is our faculty. Obviously, I'm the fellowship director. Dr. Brett Chapman is my colleague. Dr. Gina Nguyen is one of our past fellows. And we also are embedded in the plastic surgery division. So much of our fellowship is obviously focused on limb preservation and plastics. Dr. Serletti is our chief of plastic surgery, and he's going to be the new president of the American Society of Plastic Surgeons. Dr. Fisher also is a plastic surgeon who's very heavily involved in research. Dr. Stephen Kovac is a world-renowned limb reconstructive plastic surgeon. So we have really good, diverse faculty. And then Dr. Gina Palazzi is our current fellow, who I think is on the Zoom call here, and a list of our prior fellows who are all scattered across the country here. So we're 1 year ACFAS accredited, now conditional status, now that we're back into effect. The bulk of the fellowship is through our 3 fellowship podiatric attendings. And really the main focus of our program is to provide our fellows with flap and plastic surgery reconstruction, which is something that you may not get a whole lot in your residency training. And that's really what we want to highlight in our fellowship. We are embedded at the Hospital of University of Pennsylvania at Penn Medicine, which houses 2 large hospitals, as well as Penn Presbyterian Medical Center. And we also focus on external fixation. My practice is very heavily involved in minimally invasive surgery. And again, to highlight the advanced limb preservation, we do transverse tibial transports, deep venous arterialization, and we have our multidisciplinary Penn limb salvage team. So it's a mix of both outpatient and inpatient procedures and just the overall lay of the land. So we hope to kind of highlight that throughout your fellowship year. We do have an attached residency program a few blocks away at Penn Presbyterian Medical Center. There's 16 residents, so there is a collaboration with the residents, which has been very, very impactful for both sides and a synergistic effect. We have a wet lab tissue facility, which is fantastic, weekly academics, and we're very heavily involved in research. We have our own research coordinator, and we have 4 research fellows, aside from Dr. Malay's research fellows in podiatry. So again, we are embedded in the Penn Advanced Limb Preservation Program, focused on diabetic limb salvage, ischemic neuropathic wound salvage, as well as limb deformity and post-traumatic deformities. The fellow does have a clinic 1 day a week where they're seeing their own pre-op, post-ops, and new patients. So I think that's a really great thing that I know I enjoyed when I did my fellowship here a few years ago. It's a high volume, multidisciplinary practice, again, both inpatient and outpatient. And like the other fellowship directors alluded to, we really try to focus on that practice management, billing, and efficiency. So there's a very high volume practice, both inpatient, outpatient. which we think is a good mix for our program. It's a competitive salary. It's based off your PGY year. Obviously, insurance. You do get surgical loops through our plastics department, a dictation device, paid CME, our annual college meeting, 21 days off. Our current fellow is now on her 2-week Mohs rotation, which is really, really great. The fellow does go to the Chicago Limb Society program out in Chicago, which is an orthoplastic symposium. And obviously the ACFAS requirements for posters and manuscript submissions of which we adhere to. So again, the hospital that we mainly work at is the Pavilion. It's a massive, massive hospital. It's its own city, essentially. $1.6 billion, 1.5 million square foot hospital. There's lots of OR, so there's lots of activity. We also have the old HUP, which is Hospital of University of Pennsylvania. So there's a lot of total beds there. This is the Penn Presbyterian Medical Center, which is a level 1 trauma center. And like we talked about with the residents also kind of rotating through our hospital. These are just a couple of things, obviously when we're attached to a limb preservation, we see a lot of ischemic and difficult problems. So we do, again, deep venous arterialization, transverse tibial bone transports. Again, the fellowship is very in tune with flap reconstruction, so you'll see a lot of tertiary care referrals for non-healing surgical wounds, whether that's diabetic limb salvage or reconstruction. So here's a case of doing reverse sural flap with an offloading flap frame. These are a couple cases just this week that I wanted to highlight. Again, my practice is very heavily involved in flap reconstruction, so we get a lot of referrals for non-healing wounds. We do a fair amount of medial plantar artery flaps, probably about 20 a year. So this is a person that we did it this week, doing a island-based medial plantar artery flap with a offloading simple frame. And then this is us rounding today, listening to the flap with the Doppler. Hopefully you guys can hear that, excuse me. And then here's another case from a failed atrophic hindfoot Charcot fusion. So here we ended up taking the hardware out with a peg and hole tibial-calcaneal fusion and a hexapod frame application with a distal tibial corticotomy in conjunction with the gradual length extraction to get him back out to length. Here's the tibial corticotomy. And then this is a case that we just got to after we staged everything and did a lengthening and then nail with an antibiotic-coated CERAMENT G nail. So we do have trauma. We do have an elective outpatient practice as well. So it's a good mixture of everything. I don't know if our fellow's on, if she'd like to add anything. I know we're running out of time here, but thanks everyone for joining in.
Yeah, I would say the presentation's pretty spot on. I think the best thing I like about this fellowship is that we cover such a broad range of different cases, and we just see such interesting pathology. The main reason that I decided to pursue this fellowship was orthoplastics. It was just not something that I had like heavy experience in residency and my previous fellowship. So I was able to jump into this and learn from Dr. Brownell and then the plastics team as well, just tissue mechanics and rotational flaps, just such a different view and such a different mindset compared to like your regular podiatric surgical training. So it's been really awesome. And I think the one thing that everyone's mentioning is cases, and I was just looking back at my cases. I think I have I'm a little behind, sorry, Dr. Brownell. But I have about like 350 right now, so I'm probably on pace to get like close to 650 or 700 because we're always cranking out surgeries. So
Awesome. Two quick questions. Are you able to sponsor H-1B visas?
It's a hot question. Yeah, so we do have space. Obviously, we're at an academic university, so there is space for that through our university. Yeah.
Awesome. And how would you like potential fellows to contact you? Is it on the last slide?
Yeah, I don't know if I'm still sharing it, but yeah,
You
on
are.
the last slide, I have my contact information. We also have it on the college website through our ACFAS fellowship page. So that's a great way to reach out to me.
Awesome. Thank you so much. I really liked your FLIR camera pics.
Goes with
Uh,
me everywhere. Yeah.
yeah. So surprisingly, even though we're a PEDS fellowship, we've done a couple of the transverse tibial transports, and that FLIR camera does come in handy. But we're definitely not using as much as plastics fellowship. So thank you guys for your time. We're gonna move on to our next fellowship, which is a Michigan Advanced Foot and Ankle Reconstructive Surgery Fellowship with Dr. Dunn. Dr. Dunn, please take it away.
Sure thing. All right. Well, pleasure to join you all tonight. I listened to a few of the presentations so far, so really great to hear about all the different fellowships involved with ACFAS. I did my fellowship 12, 13 years ago with Jason Miller out of Pennsylvania. And back then, I think there's 18 programs, and now we're, what, close to 60 or so. So, or maybe more. So it's been growing a ton since I graduated. And obviously, well, hopefully I don't look too old. But I had this idea to start a fellowship a few years ago, and it's gone really well. And we've gone through some recent changes, and I think continues to improve. So, again, my name is Karl Dunn. I'm representing my fellowship, the Michigan Advanced Foot and Ankle Reconstructive Surgery Fellowship, out of Lansing, Michigan. My current fellow, Justin Garvin, past fellow, Kana Patel, and incoming fellow next year out of Indianapolis, Zachary Holst. The fellowship is 12 months. It's recognized by ACFAS. It starts the 1st of August. I know it's been a hot topic, so I added this in. We are not supporting H-1B visas at this time, unfortunately, even though we are an academic hospital. So that may change in the future, but currently we are not. When I started this fellowship, and like I said, this is a relatively new one. This is only my second, going into my third year. I had the core principle. Would this be a fellowship that I would want to do when I was graduating as a resident? And since I did an ACFAS fellowship, I know what I liked and didn't like with my experience. I had an overall amazing experience with Jason Miller in Philadelphia, and I wouldn't change a day because it was such a great experience, and I wanted to replicate that experience that I had. So that's kind of my core principle. So back to myself and how the program is run. We've had some pretty big recent changes since starting. So I was in practice for 10 or 11 years out of a larger orthopedic practice in the area. And then I was recruited, fortunately, to join University of Michigan Health in my same area. And so I got recruited and I joined practice with the orthopedic surgeons there as the only foot and ankle surgeon in the practice, which has been great. And it's been a really nice transition for myself and for the fellow. So our focus is really just on adult foot and ankle reconstruction. I do some peds, but not many. We'll do some pediatric flat foot correction, but we actually have an orthopedic pediatric orthopedic surgeon who does foot and ankle as well. So there's opportunity there in the future to establish more of a relationship. But we specialize in complex deformity correction, limb salvage, Charcot reconstruction. I don't do standard diabetic care, but I will absolutely do Charcot reconstruction to try to save a limb. I do a lot of ankle arthroscopy, sports medicine, total ankle joint arthroplasty, revision care, minimally invasive surgery. I've been doing that since about 2017, so since it really started to gain favor in the publications. We do 3D and custom molded implants and gradual correction and external fixation. So the training environment, basically it's one-on-one supervision. And in the future, we'll talk about goals of the program because there's a lot of opportunities. But right now, it's basically one-on-one mentorship. There is no residency that I train at the moment. And I don't plan on training any residents anytime soon. I used to be a part of faculty for two different residencies and trained a lot of the second and third years in those programs. So it's one-on-one mentorship, and again, it's the clinical and surgical experience, trying to really get to know your patients, how to work with them, provide very good care, establish a good bedside manner, understanding billing and coding, understanding the surgery and what goes into surgical correction, and then the proper follow-up care. So we have a good multidisciplinary approach at the academic center with the limb salvage team, but we have close collaboration, especially in the office. The docs that I share space with are, orthopedic traumatologists and knee arthroplasty surgeons, etc. But we work well with vascular and infectious disease in our hospital. So again, one-on-one mentorship, and I really I tried to provide surgical autonomy throughout the year. Everyone kind of comes in at their own level based on their training, and some people are more capable than others, and other people don't need as much of walking through an MIS bunion as other people because they really had great exposure. Other people, it takes them towards the end of the year to get through that learning curve and to do well. So again, my foundation is that I really want to make this about the fellow for the fellow. I want to provide the best training experience for them. So I'll work with them wherever they're at in their training, their shortcomings, and try to improve where they're at with their skill set so they can be the best that they can be when they graduate. We're very high volume. I spend 2 days, full surgical days, and 3 days in clinic. We have add-ons from there. That being said, thankfully, we don't have to do too many late night add-on cases. So that is a big benefit too. There is a good work-life balance in this fellowship. So a little bit more about the recent change at the hospital. A fairly large hospital that we work from, 730 beds. It's a level 1 trauma center, so we get a fair amount of trauma. We do have full-time orthopedic traumatologists. So oftentimes what will happen is they might manage the patient initially, and then they kick the patient over to us when appropriate. But we're not going in at midnight and washing out PLN fractures, etc. So that's kind of nice. So we get what we call a country club trauma. But on top of that, I have a great referral population. I've been in the area for 11, 12 years. So I get a lot of second opinions from everyone else in the area. And it's really my pleasure to take care of some of these complicated patients and work well with the other podiatrists and foot and ankle surgeons in the area. We do some limb salvage and diabetic reconstruction. We don't do any chip and clip whatsoever. And again, we're trying to manage these complex cases. So a lot of academic opportunities, and this is kind of where we're growing in the future. As we're growing the fellowship in general, we're working more with the Academic Medical Center based out of Ann Arbor. They have their own research fellowship, and we're starting to collaborate more and more with them, which can help research for both institutions. And I think that's really something that we're striving for in the next 1 to 2 years. But again, my job as fellowship director is to make you the best possible surgeon, not only in the operating room, but out of the operating room as well. So I'm trying to provide that strong mentorship for anybody who comes through the program. So since we're a newer program, I have to tell you about my goals because this is our second going into our third year. So the goals of where we're at now, and I think the goals have been set higher since moving over to the new institution. Again, collaboration with University of Michigan Hospital, the Academic Medical Center in Ann Arbor, to grow the ankle and foot service line. Right now, again, I'm the only employed foot and ankle surgeon, podiatrist, MD, DO in the hospital. So we're very busy, and there is plenty of opportunity to add other great attendings, but also other staff in the future. So that's kind of my presentation. I know it was pretty brief, but I was just really excited to talk to all of you tonight and kind of tell you about where we're at and really what's to come in the near future.
Great presentation. Appreciate it. You already got my H-1B question. Good job. And you have your contact info. So really the only other question I would have is, and you did put the dates of what your fellowship is. What are you looking for in a fellow?
Yeah, so the biggest thing is somebody who's very motivated, who is somewhat independent, who can try to figure things out on their own, but if they get stuck, they're not afraid to ask. So really, I'm looking for somebody with a great deal of motivation. Um, I think you have to have somebody who's very honest and open and have a good discussion um, because that's really where the mentorship comes from. I love it in the operating room. when I see a fellow kind of cruise through certain parts of a procedure, and then they'll turn to me and they'll say, I know you just showed me last week. Can you show me one more time to get through this part of the procedure? And it's really cool to see that because then I remember the next time that we do that procedure and I can really pay attention to see if they picked up on that or not. So somebody who's willing to have that conversation, open, honest, and motivated, I would say.
Great. Well, we really appreciate your time. Thank you. You have your contact info if anybody would like to reach out, and it's also available on the ACFAS fellowship page. Thank you so much for your time. Dr.
Thank you.
Dunn, have a great evening.
You too. Thank you.
So our next presenter is the Dr. Chokon from the Revisional Reconstructive Surgical Fellowship at Ohio Foot and Ankle Center. So if you'd like to take it away, please.
All right, thanks, guys. I've just watched some amazing presentations. Hopefully, I can keep up with everyone also. So let's see if I can get this done correctly and get this started. So can everyone see that okay?
Yeah, you just want to put it in presenter mode. If you
Yeah.
can.
Let's see if I can do that correctly. Is that correct?
Perfect.
Right. So as I was watching a few go through their, fellowship, we've been around for 5 years, started in 2020. We've had our ups and downs for sure. We had some that only lasted a few months. They went on to do something else. Some signed contracts and said it wasn't what they wanted to do in the beginning. So, truthfully, it is one of those things that fellowship may not be for everyone. So you go through that process of who's it for? What are we looking for? I kind of call ourselves small but mighty. It's just myself right now that runs this fellowship. We've been able to get some sponsorships from different programs to be able to keep it going. As of now, I have other orthopedic friends that I don't consider them full attendings, but we can just easily call on them, or as a couple other fellowship directors that talked about, it's what you get out or what you put into it. So if you're a go-getter and want to make a call to one of our orthopedic friends and essentially reach out and say, hey, do you have cases? It'd be great if you could, then add more to your caseload. So these are our attendings. This is my last fellow. This is Dr. Manitti, who was my fellow last year, who's now attending with me at our practice. So it is a nice thing that if we can keep fellows at the same time, they learn the way the program works, the way the office works, the practice management. It's great to move them into the next episode of being an attending. So like I said, 2020, some have completed, some half completed, others decided to move on to something else. We do have a strong emphasis on practice management, as I've been in practice myself for 23 years. I do try to get about 400 to a little bit more than 400 cases a year. We try to do 10 a week if we can. Sometimes it's not that many, but again, we do practice probably 3 days out of the week, and then the other 2 days are surgical or heavy wound care, if you will, and things that you can do outside that time. I try to give the fellow a few hours during the week to try to work on their paper or poster that we're working on. Big thing that I love is that if the fellow is working, which again, we try to make it full autonomy, they can see their own patients, they can book their own surgeries. I want them to book their own surgeries, as Dr. Al was talking about, that he gets, they learn the hardware. Same with Dr. Rubin, you learn the hardware, you get to choose the equipment, you get to make this your own case, which again, sometimes I see when, we're dealing with residents. I do work with residents also, which is a university hospital residency. I've worked with 3 different residents over my years with St. V's, Alliance, and those other Ohio ones. But the one thing I see is the residents who are now getting out just are unsure too much about what they want to do with their first year out. So I think fellowship gives them that confidence to really understand how to do the next case, how to understand how to throw a wire, put the hardware in, be confident with their incision placement. So as I'll show, I did pass residency director. I have 3 locations, and I'm always trying to add for more doctors. Like I said, they come and they go. Some don't stay as long as I like. And then I'm a consultant for a few companies. And then I guess my claim to fame is how many Lapiplasties I do in a year. So that gives me so you will learn that, whether or not that's not your thing. I'll still do MIS, but I'm kind of concentrated in that Lapiplasty center. But we'll do forefoot surgery. Like I said, I'll do MIS, forefoot cases, wound care, ankle arthroscopy, Charcot, total ankle. Like most of these other places I've seen are all, 3D implants, total talus, total navicular, X-fix, talar spatial frames. Like I said, we've learned a lot of this on how to do it. I do think that you can work with my orthopedic friends. I can do calcaneal fractures that I might not get. And then I do get some trauma. It's just not heavy in where we are because I do have a lot of orthopedics around me that, kind of take up those cases. But we will get them if they at our different location. There are a couple of hospitals that I do get more trauma. We do inpatient a good bit also. We're on call a few places that we do have to take a full week call if you're going to get your dirty cases. And for me, it's a long day. We'll see 60 patients a day at times. Certain months are slower. Right now, we're only at the 40 patient number, but the fellows will be with me on probably 1 to 2 days during the week. And then I want the fellow on their own, seeing patients, learning how to code, learning how to bill, practice management. Time management is important. So goals, of course, learn effective creative billing, learn to run a business if they're interested in that. Some want to be on their own. Some like what that looks like. Running a business is not the easiest thing. Dealing with employees, set yourself apart, how to brand your company, manage the office, manage surgical cases. You're going to see your post-op, pre-ops. You always want to see the pre, peri, and post-op, of course. As a resident, I don't think you get to see all of that. We're on call every 3 weeks, since it'll be myself, Dr. Menidian, the fellow, and again, every 6 weeks. This is our salary. It runs from August 1st to July 30th. Surgical, I want them to get all the cases ready, deal with the surgery scheduler, choose your equipment, learn to book the cases at the hospital or a surgery center, as we'll have a surgery center opened up in April. Prepare for the cases, look at the MRIs, journal clubs that I'd like to get started. That's the one thing I've been missing since we don't have a fellow right now. So we are wanting to fill the spot for what's considered the 26, 27, even that year coming up. I always want you to present a case of the journal clubs if you can, and then we do a research and a poster presentation. And again, they get full medical coverage, and again, still dealing with the autonomy. Clinic, like I said, 30 to 40 patients a day if you can. Learn billing, learn how to time manage, and then again, going through the cases. These are my faculty that I talked about. Dr. Glass and Dr. Corpy are the DO orthopedics that they can always reach out to. We do start cases together, but I'd love for them to be able to do cases on their own. These are some office pictures of my offices, so you can see that they're not just some rundown small place, but you do get a large place to at least work, and places you can sometimes disappear to, I guess, if you're not interested in seeing patients. Cases, like I said, it's large reconstructive. So we'll do total ankle, total talus cases. This is actually a 40-year-old female, has an AVN of her hip, and did not want to do a fusion at this case, and she had AVN of her talus. So kind of figuring out what's really wrong with why she has AVN in a few of her joints. We'll do necrotizing fasciitis. This is after the AMP skin grafting, and then I think we put a frame on her also. So I do use, learn to use dermatome measures for revisional cases. This is, again, some of the trauma we get: an open trimal fracture, X-fix use. And again, people are talking about tibial transverse transport. So I'm booking my first in about a few weeks. So that seems to be a going trend also. So I can fly through things. I probably talk too fast. But I'm interested in knowing that a lot of this that we do is, like I said, you'll do a lot of cases. You'll see a lot of stuff. And if really what it is that if you say, hey, Dr. Chokan, I want to do this case, I want to do an MIS Keck and Kelly or an MIS calcaneal something, it's fine. We can handle it. Just you need to learn about it, read about it, and put it together, and then we'll walk you through it. So And the big thing is that, like I said, I wish we had a more frequent fellow, and sometimes we have one, and sometimes, like this year, I just haven't had any candidates that I don't recommend I don't, maybe I should say I don't always need a visitation. It is nice to be able to learn the person if we can't do a video chat of any sort. And sometimes they want to see what the place is like, but I know it's hard if you're busy and you can't get out to visit. So I don't make it a requirement. It is one of those things that sometimes it's about meeting the person and seeing what they're like in the operating room if you can. But you can reach out to me any chance you get. We are looking for someone, like I said, this year coming up, even though probably a lot of fellows are being interviewed for the next year, but we're happy to take someone for next year also. That's probably what I got so far.
Perfect. Your timing is excellent because you got exactly the 10 minutes. I really appreciate that. And
Sure.
you have all your contact info. So,
Yeah, they can reach
know,
out. That's my office number. You can always reach me. My cell phone was a couple slides back, but office is easy. My manager will just get in touch, and then always, can reach out with an email. That's easy.
perfect. Thank you so much for your time this evening. And
All right, thanks.
you're welcome. We're going to
Thanks,
go
Mark.
on to our next program, which is the Silicon Valley Comprehensive Foot and Ankle Surgical Fellowship with another man who needs no introduction, Dr. Matt Doyle, and one of my former residents. I'm going to just call her Dr. Hannah because I always butcher her last name. And I believe they have another person, but I'll let you introduce your crew, Dr. Doyle.
Yeah, thank you, Dr. Solomon. Appreciate it. Yeah, so we have Henna Akbarzai. She's our current fellow, and Tim Chung, our current fellow here. So the fellowship director is Megan Jennings. I'm the assistant fellowship director, and our program is in Sutter Health, Palo Alto Medical Foundation, and the Silicon Valley, Northern California. So, what do we really do? Who are we? We're a multi-specialty group of about 2,000 physicians around the Northern California area. We fall under an umbrella of Sutter Health, which is largely a West Coast, Northern California health system, and they help support us. So we fall under them. Who we are, we're about 10 attendings in our group that range from 5 to 6 years of practice to 35 plus years. So we have a wide range of podiatric attendings here. We fall under the neuromuscular service line. So we have some orthopedic doctors, sports medicine that we work with and are right down the hall from us that we collaborate on cases. Some of these doctors are involved in professional sports teams. So we have availability to work with specifically the local Bay Area football club here in San Jose. And you get to be on the field for games. You spend some time with these orthopedic physicians and sports medicine doctors in clinic and the operating room as well. So you have one-on-one time with them. So they're a big plus for our group, and we collaborate with them quite a bit on many different patients. There's a full scope of practice, so we do everything. I think one of the most common things we get asked when people email, call, or visit, and they say, "What do you really do?" We do everything. We do a lot of sports medicine, trauma, reconstructive surgery, flat foot, cavus, minimally invasive surgery. We do all of those things. We are not a heavy external fixator diabetic practice. We see some Charcot here and there and treat those things, but that's not the focus. I'd say that's probably 1 to 2% of our practice. Our complicated diabetics have an A1C of 7. So it's a different area, a largely healthy, active population. We do get our diabetics in the hospital, though. We have 2 fellows per year. The salary is $100,000. Okay, so California can be an expensive place to live, so we definitely compensate people, and that is more than enough to save some money, pay some loans, and live pretty well while you're in Northern California. We have one main facility where the fellows have their own office and practice. And we have 3 surgery centers where they typically operate at. One in Mountain View, one in San Carlos, which is about 20 minutes north, and then one in Los Gatos, San Jose, which is about 15 to 20 minutes south. But the home base is Mountain View for the fellows. That's where most of the attendings are in the practice. We do have one main hospital system called El Camino Hospital. There's two local EDs. However, one of the EDs is our main site where we see most of our inpatient trauma, open fractures, and that's where we get any of our diabetic foot infections. Fellows do take call. So they typically rotate a week at a time. It is different than residency call. It's kind of a gentleman's call most of the time. Fellows are not going in after hours. This is daytime stuff that they have ample time to answer consults and see things during the day and get things teed up if they need to operate on patients in the hospital. So cases, again, wide variety. We see ankle fracture dislocations, arthritis. We see some frames, Charcot patients that need this from time to time. A lot of sports medicine, lateral ankle instability, peroneal tendon pathology, very common. Bunions, both open and minimally invasive. External fixators, delta frames for fracture dislocations and pilons. Bunions, MIS there. Fracture fixation, again, open fractures in the hospital. And what we see about for patients and fellows per year, generally 600 or more cases, some years up to 700 per fellow. So that's almost 1,500 cases for two fellows in a year. Fellows do get to have primary cases. So they typically walk away from fellowship with almost all of their cases for boards. If they do happen to get some patients in their little pseudo practice, they may get elective cases as well, bunions, flat foot, arthroscopy, anything that will count towards surgical boards. So typically fellows are leaving, and by the time they get into practice and see their first patient, within a couple months, they've met all the criteria for ABFAS surgical boards. So that's a big bonus there for our fellows. So our types of cases. So our foot and ankle trauma, we get a lot of trauma through our urgent care and our EDs. We definitely have high volume Achilles tendon ruptures, ankle fractures. Those are two things that we see high volume of and do several every week. We do get a small amount of pilon, calc fractures, talus fractures, a fair amount of Liz Frank injuries as well, mostly low to moderate energy injuries. We're not a level 1 trauma, so we're not getting the car accident type of Liz Franks. However, they do come in sometimes. Jones fractures, metatarsal fractures. We have 4 or 5 surgeons that do minimally invasive surgery, including myself, minimally invasive bunions, calcaneal osteotomies, flat foot and cavus recons, Hageland's deformities, lesser metatarsal osteotomies. So very high volume and minimally invasive surgery, between 4 to 5 surgeons that do this. Definitely do a fair amount of flat foot and cavus recons, both periarticular osteotomies as well as arthrodesis. We do about 15 to 20 total ankles and ankle arthrodeses per year between myself and one of our other surgeons, Dr. Yergalon. And these include both primary and revision total ankle and primary ankle fusion. 2 of our attendings, Dr. Tanaya West and Nick Bolanini, do Ponseti clubfoot casting. So we get local referrals for that, and they typically at lunchtime have a series of casting that they do every week and are spending on kids doing this. So very well rounded. I would say our sports too. We do a ton of sports, a lot of lateral ankle instability. I'd say most fellows walk away with 50 to 75 arthroscopic procedures as well. So very high volume in arthroscopy and very well rounded. I looked at my case log just from the last 2 to 3 months, and this is the range of cases that fellows see. So everything from pes cavus reconstruction. You can see a case in the lower left there of someone who had a gunshot wound and someone outside excised the entire metatarsal, and we did a vascularized fibular grafting with plastic surgery, so we can team up with plastic surgery for complex cases. Primary and revision total ankle, ankle fusion, lateral ankle instability, flat foot reconstruction, trauma, fractures, subtalar fusions, and definitely MIS surgery. So really a vast array of the types and complexity of surgery that we see in our group. So labs, case presentations, we have monthly case reviews, preoperative conferences, postoperative conferences, where we all get together, fellows present cases, and we discuss pertinent things relative to those cases for group teaching and for fellow teaching. And it's kind of an open, safe space where we can all learn from each other, and the fellows help teach us, and we help teach them. So it's a give and take. We have lots of labs. We have a local Arthrex lab. So we were just there yesterday. We can go to this lab any day of the week, Saturday, Sunday, whenever you have time. And if you want to work on something, it doesn't have to be related to a specific product. It could just be a procedure and dissection, arthroscopy, anything you want to do. You can get in the lab, and we have our own lab that we can sit in there, and you can spend 2 hours practicing arthroscopy and working on your skills for that. So having a local lab is really beneficial. And we get a lot of local support from these companies, which is great. Our schedule, OR days, typically Monday through Friday, usually one day, either Wednesday or Thursday every week. One of the fellows has a full clinic schedule. They do get to run their own schedule, which is really, really important. And they can bounce ideas off the attendings. They can see someone, and they could have a tri-mal come into their office, or a bunion, and they will work this up, and they can present to one of the attendings, and this is their case that they get to work on and be a primary surgeon on this case. So again, call schedule 1 week on, 1 week off. Sometimes fellows choose to do it 2 weeks at a time. Again, this is not called like residency. It's more a gentleman's call. So you're not getting called all hours of the night every day of the week. That's very sparingly. Our deadline's typically April. We let people know by mid-April. So we get visitors earlier in the year, and then typically we let people know by mid to late May. So here's just some of us from ACFAS last year in Phoenix. Desire is the key to motivation, but it's the determination and commitment to an unrelenting pursuit of your goal, a commitment to excellence. So kind of like what most people already said on this, it's you get out what you put in. This is a highly demanding year. Everyone that visits, I say, do you expect residency or fellowship to be more difficult? And the answer should always be fellowship. You're grinding, and you're spending 12 months of your life to try to get as much out of it as you can. So
In
we're
that
not trying
sense,
to.
oops, since we have to kind of wrap it up, how would you
Yeah,
like
that's
people
that.
to contact you?
Yeah,
Perfect.
right here. This is it.
Great. And do you have ability
Yep.
for H-1B visas?
I am not sure. I know that got brought up earlier. It has not come up before. I'm not sure.
Okay. Appreciate your time.
Yeah. Thanks, Doc.
Great job. And we have our last fellowship now, the Center for Advanced Foot and Ankle Surgery Fellowship, uh, run by Dr. Holtzman, who I believe has his assistant director on.
Yeah.
Is that correct?
Yeah.
Sure. Would you like to introduce yourself?
Yeah, so my name's Dr. Kira Ben-Shea. I'm the Assistant Fellowship Director at the Center for Advanced Foot and Ankle Surgery in St. Louis, Missouri. We are a newer fellowship, so this is our third year out. We have someone selected for this upcoming year, but looking for somebody for the 2027-28. We've had a couple people who've came and visited so far, but we're still looking. A little bit about our fellowship is that it's a create your own adventure. So we have a lot of really great specialties and lot of really great docs to work with. So whether you're looking at trying to gain some skills that maybe you didn't get as much of out of residency, or you're looking at trying to build on what the concepts you already learned, whether it's clinic and billing, or just doing more big recon cases, or doing trauma or plastics, we kind of have that. And rather than me just kind of sit and talk about how great the program is, I actually have our current fellow, Dr. White, who has a presentation and some stuff he'd like to talk about, and just kind of someone who's more closer to being in your shoes talking about what's going on.
Yeah, so my name's Caleb. I'm the current fellow, and so I'm just going to share my screen, make sure I can do this right, and then just kind of have a quick presentation, just kind of running through who we are. Kier kind of gave a good introduction. So, like I said, who we are, we're located in St. Louis, Missouri. Our director is Dr. John Holtzman. Our assistant director you just met is Dr. Kira Ben-Shea. Primarily cover two different hospitals. They're about 20 minutes apart. St. Louis traffic is nothing compared to from Miami, so this is nothing. And we have about 10 attendings in our group, and these are kind of the main attendings we work with. Kira was saying it's like you kind of make this what you want. So you have lots of different outsources, and I'm the third fellow in the program, and so I kind of have my own niche of who I like to work with. and where I want to grow in my expertise. But these are kind of our primary guys who you're kind of with typically. And so just a kind of quick, kind of like what my day-to-day schedule looks like. So on Mondays, I do my elective surgeries with Dr. Holtzman at the surgery center. We go in and you're just one-on-one with him. It's you and him. And so it's pretty great. And then Tuesdays is primarily with him in clinic and really focus a lot on billing. I thought I had a good concept on billing before I came in. And then in clinic, when it's on your own, it was a lot different. And so he's really great about telling you how to bill correctly and to do it efficiently in between each patient, so you're not going home with the whole ton of notes. That was huge for me, and I was very slow at first, but now I definitely have the hang of it. Wednesdays and your Fridays, I spend with our orthopod, Dr. Buck Smith, and he's really big on reconstruction and honestly, like kind of what happens when something fails. Usually second cases that are just a lot of revisions, and that's what my Wednesdays and Fridays look like. Usually I have around 8 to 10 cases that day. And what's great about that is that he has 2 rooms. And so he will bounce back between 2 rooms. So he really enjoys you having there. That hospital has no residents or fellows. And so you're like his go-to guy. And so it's really great. And there's a lot of hands-on learning from there. And he's a great surgeon, great guy. So it's really great that you get to be in that OR with him a couple of times a week. Thursday, you have your own clinic. And so this is where the fellow runs their own clinic. You see your post-ops. We do all of our surgery, or you can do surgeries in your name. And so this is where like the patients that you see in the hospital, you do surgery in your name, they come and they follow you throughout the week. But this is kind of, like I said, just my schedule, more of what you make it. Those attendings each have a different specialty. Saying like we have a really big plastics guy at our hospital, and he's consistently always there, so you can work the schedule around them. We have call at 2 different hospitals, and so one hospital is a buddy call. So like Dr. Benj and I are on call at that hospital, and we tag team and help each other out, which is really great. And the other hospital has residents, and they only work with you at that hospital, and it's really great because they can help you do a lot of their notes, do a lot of the rounding, make it a lot more efficient. So it's not entirely kind of just on you. It's you get to see a lot of that stuff, but there's also a lot of teamwork that helps out a whole lot. So kind of more of like, what do we do? Types of cases. So this was the first 4 images on my left from my very first day. The TAR, ankle fusion, TTC, and then an ankle fracture. And I think we had a lapidus or something in there too. And so this is just my first day, and it's kind of just generic stuff we do. Like I said, a lot of it is revision, and a lot of it is kind of dealing with trauma because our 2 orthopods are trauma doctors for it. And then I'm just a big Star Wars guy. And so the top right corner, I thought, like when we do that procedure, I think it's really cool because we call it Death Star. So that was fun. And then benefits. So current pay is 60,000, but for the 2027 fellowship, we're in the works to bump it up to 75. You get $3,000 for CME, and this is separate from your ACFAS budget. So my ACFAS trip did not affect that at all, which is very nice. And so, and you have the opportunity to go and learn on 7 different conferences. I love conferences. I love to learn. So I've been on 4, and I'm going on 3 more this spring, and those are all covered. And so this is a lot of benefits for you to go out and learn, and I really like to do that. 5 days of PTO, but the courses do not count towards your PTO. And there's a big one, reimbursement with moving. It costs a lot of money to move. I moved from Miami to St. Louis, and that was all covered. So that was really, really helpful. And then just St. Louis, just lots to do. And so there's baseball, NHL. You went apple picking for the first time. They have an IKEA. You can go anywhere that has IKEA, in my opinion. And so that's kind of basically it. And so let me show you that's my fault, our contact information. So like I said, we've had people visit. We are still in the works for looking for somebody. So please come text us. We'd love to hear from you. And so we'll decide later in about a month, I think, what the date is, Kira. And so but we'd love to have you reach out, shoot us an email. Best way to reach us is honestly just come see it for yourself. We'd love to meet you in person. We'll take out to dinner, all that good stuff. So
yeah. And texting us is probably the easiest and fastest way. And believe it or not, I really am, like, any day or night, like even if it's late at night, because I know the resident schedule, feel free to shoot over a text. I will respond to it in the morning because I know that schedules get hectic, and it's just easier that way just to keep that open line of communication, just because I know that around this time, interviews and everything, we want to make ourselves available for anybody who's interested.
100%.
Cool. So a couple questions. First, are you guys able to sponsor H-1B visa?
We cannot.
Most private practices can.
Yep.
Okay. Can you go back to that what St. Louis is famous for screen?
Yeah.
So Are those fried raviolis? Is that
Those are
what?
toasted ravs,
Toasted raviolis,
absolutely.
and I never knew that was a thing until I came here, and now I can't stop eating it. I hate that I figured them out, and so here we are.
Where's the arch is in the background of the baseball. I was gonna say where's the arch, but
Yeah, I
I
kind of
see it
tried
in
to
the
include it
background of
with
the
the
baseball. Yeah,
with the baseball back there.
cool. Um, I appreciate you guys' time. We're finishing like 2 minutes early, but like leaving the contact information at the end is always great. You guys, how many where do your fellows end up?
So I was the first fellow and I stayed. Our second fellow, Dr. Narrowitz, actually joined USFAS and is in the process of transferring out to their Carolina location. He actually was able to stay on, he and his wife are both podiatrists. They stayed on locally for the last 8 months, just because with the Carolina licenses, as I'm sure we all know, that's a separate board exam and it's a very timely process. So they actually were able to stay employed rather than take a huge gap. So they're actually in the process of moving out there. And then Dr. White, where are you headed to?
That is a $1 million question that everybody that I know keeps asking me, and so stay tuned. You probably know in a couple of weeks.
He's had multiple offers. He just hasn't made a decision. So I promise he is employable.
Yeah, oh yeah, for sure. It's
That's
just
fair.
a matter of where are we going.
Awesome. Thank you guys so much for this evening. Really appreciate your time.
Thank you.
And the recordings will be available for anyone that's still looking for any information about any of the fellowships that have been presented tonight. So thank you all. Again, appreciate everyone's time for being here tonight, and have a great evening.